Thank you, everyone. I'm Dr. Ashley Ross. I'm an associate professor of urology here at the Northwestern Feinberg School of Medicine. We have a continuing medical education course, which you're attending right now, called Updates and Advances in Urologic Oncology. And in regards to kicking the year off with this course, I thought we might talk about prostate cancer, a year in review. There's so much happening in all the different genitourinary disease states for oncology. And I thought we would just go on a little bit of an overview of it. And when I was thinking about how I wanted to frame things, I thought I would look at the FDA approvals for prostate cancer over the last year and maybe talk about, how those fit into our daily practices, how they change things. What are my thoughts on some of the evidence that it's based on? And what we can see over the last year was several approvals. In May, we got another PET PSMA imaging approval. This is with RH PSMA 7.3 or flutafulastat, and that was approved for staging of prostate cancer, both at initial diagnosis and also at signs of recurrence. And additionally, through May through August, we got 3 different approvals for first-line metastatic CRPC, castrate-resistant prostate cancer, using Parp inhibitors combined with an androgen receptor, pathway inhibitor, either olaparib with abiraterone, niraparib with abiraterone, or talazoparib with enzalutamide, and those were in men either having BRCA 1 or 2 alterations in the case of the olaparib and abi or niraparib and abi, or multiple homologous recombination repair deficiencies genes for talazoparib and enzalutamide. And then more recently, we saw an expanded approval of enzalutamide in the non-metastatic castrate-sensitive prostate cancer space. And so I thought we would go over these and essentially touch on, PET PSMA imaging that's become sort of pervasive in our practices, implications around that. We'll talk about the RH PSMA compound and how it's changing things a little bit, or could a little bit. I'd be remiss if I wouldn't talk about radioligand therapy. We didn't see a new FDA approval this year, but we saw multiple reports of maturing phase 3 trials with radioligand therapy. And then I'll move into talking about, Embark and the expanded approval of enzalutamide and androgen receptor signaling blockade. And then finally, we'll talk about Parp inhibition in prostate cancer. So let's dive right in, starting with PET imaging. So, as hopefully everyone knows, but the audience may be a little bit mixed, prostate-specific membrane antigen, or PSMA, is a transmembrane protein that's highly overexpressed in prostate cancer cells as opposed to normal prostate tissue. It can be 100 or 1,000-fold overexpressed. And it allows for the ability to target that and thus target prostate cancer either for imaging with some kind of positron emitter like gallium-68 or F18, or with some kind of payload that can be used to kill prostate cancer cells, whether that be, for example, a radioactive molecule like lutetium-177, which is a beta emitter, or if it's an alpha emitter, you can use that as well. The imaging using PET PSMA is now approved for prostate cancer, and there's also evidence and the FDA approval for radioligand therapy that targets PET PSMA in advanced metastatic castrate-resistant prostate cancer. So just to dive into this a little bit more deeply, there's actually multiple FDA-approved PSMA-directed small molecules. Let's think about it in terms of imaging, and there's some that are shown here. The one on the bottom left is F18 DCF PYL, which here at Northwestern we use very routinely in our practices. There's also a lot of use of the gallium compounds. This is the one on the bottom right, the gallium-68 PSMA 11. And then the one on the top is the one that's been just recently approved by the FDA, and that's the RH PSMA 7.3. All of these compounds have different chemical structures, and that means that they can have different amounts of like hydrophobicity, urinary excretion, off-target binding, on-target binding. They are similar in some ways, but they have their differences. One of the similarities is that all the compounds I just mentioned are FDA approved for imaging for men with suspected metastasis who are candidates for initial definitive therapy, and also imaging for men with suspected recurrence based on their PSAs. In addition, the FDA has approved the gallium compound for metastatic castration-resistant prostate cancer when you're thinking about eligibility for radioligand therapy with something like lutetium-177, PSMA 617. The other compounds, however, the DCF-PYL, Polarify compound, or the RH-PSMA 7.3, the Posluma compound, the NCCN and other guidelines panels say you can also use those as an equivalent to figure out if someone might be a candidate for radioligand therapy. So, I thought, even though this isn't new for this year, because PET PSMA imaging is becoming, again, so pervasive in our practices, it would be good to just review, how is it changing how we stage and then manage prostate cancer patients, and when is it even appropriate to get the imaging? As we have wider and wider use, we want to make sure that we're doing it correctly. The Society of Nuclear Medicine and Molecular Imaging puts out a very nice sort of guideline around this, and it's kind of recapitulated as well by the National Comprehensive Cancer Network. It basically gives different clinical scenarios, and it talks about, like, are they appropriate or are they rarely appropriate, and it gives them a score shown there on the right about how appropriate they are. So let's look at the places where the Society of Nuclear Medicine and Molecular Imaging says, PET PSMA imaging is appropriate, gets a high score, 8s and 9s, and let's just dive into that a little bit. So first, let's look at newly diagnosed prostate cancers that have potential for having metastasis, and staging men in those categories. These are men with unfavorable intermediate risk prostate cancer, high risk or very high risk prostate cancer, and you want to stage them to see if there's any metastases present. And there's two scenarios that the SNMMI talks about. One, the guys had no previous staging, and the second one is they've had some equivocal findings on other modalities, say like bone scan or CT. Just note that all the guidelines, and this is an excerpt from the most recent NCCN, state that, look, PET PSMA, as I'm going to show you briefly, has increased sensitivity and specificity when you're comparing it to conventional imaging. And because of that, most guideline panels, and I myself, do not believe that conventional imaging is a prerequisite to PET PSMA. PET PSMA is at least as effective at staging the patients correctly, if not more effective at accurately staging them. So, where does some of that come from? When I think about PET PSMA and why I use it as my first thing I do for staging patients when risk appropriate, I think about the pro-PSMA studies. This is kind of a almost like a real world way that you would analyze what's best, where they basically took patients with unfavorable intermediate risk prostate cancer or higher that were going to undergo initial staging, and they randomized them to either get a PET PSMA first or to get conventional imaging with a CT and bone scan first. And then after decisions were made and things like this, they would cross over to the other imaging. So if they got a PET PSMA, they would then cross over to getting a conventional imaging, and vice versa. And then they had a composite endpoint of standard of truth, including histopathology, imaging, clinical findings, etc. And what were the findings from this? What they found was, if you look on the right side, the PET PSMA is in the red and the conventional imaging is in the blue. The accuracy for PET PSMA at initial staging is higher. That's driven primarily by the higher sensitivity, but also there's high specificity for the PET PSMA. Altogether, it's about 30% more accurate than conventional imaging. There's less inter-reader disagreement, less equivocal findings if you do PET PSMA imaging. There's a higher chance that the PET PSMA imaging is going to change what you thought you were going to do for the patient. And then finally, if you omit things like the bone scan, you can actually have a reduction in the amount of radiation the patient is getting. So, what's happening in the real world? That was several years back, the pro-PSMA study was published. PET PSMA had become more widely available in around 2021. What's happening in the real world? The Northwestern hospital system is about 11 hospitals now, and a lot of the data we can query to see what's going on and what are the practice patterns. So this is a query done by Richie Bennett, who's an exceptional medical student who's working with our research group and others from my lab, where we looked at 784 men with newly diagnosed unfavorable intermediate risk or above prostate cancer in the Northwestern medicine system over the course of the last 3 years. And we looked at, like, well, how were they staged, or if they were staged at all? So 32% of the guys, mostly unfavorable intermediate risk, some high risk guys, were not staged at all, actually, or not adequately staged. Then we looked at, well, if they were staged with, bone scan plus some kind of axial imaging, or with, PET PSMA, what was performed, what was the trends in that? And as you can see, if you look at the blue line, the frequency of use of the PET PSMA went from about 24% to about 81% in 2023 in terms of initial staging of newly diagnosed prostate cancer. Conventional imaging was omitted in 61% of the cases, so they just used the PET PSMA for that staging for distant disease. So if we're using it a lot, there's some considerations that come up as people try to understand, like, where does this fit into their practice? And I again, even though this might be old news to a lot of people, and I know this is an updates of what's happening last year, I think one of the updates is that we're using this a lot. We want to know if we're using it correctly. So the first question is, and I'm going to give you the question and then my answers and my interpretation. First question I'd have is, well, should we be staging men with unfavorable intermediate risk prostate cancer? I think the answer is yes. I'm going to show you data soon about why. The second question would be, well, if the PET PSMA is negative and I'm thinking about taking a guy to surgery for me as a urologist, can I omit the pelvic lymphadenectomy? And I think the answer is no, and I'll show you why in a little bit. And then the next question is, okay, well, if I'm going to stage them with this thing that's more sensitive, I'm going to pick up more people having metastatic disease by PET that would not be that way by, conventional imaging. And so should I omit local therapy, or should I omit surgery if my plan was to do surgery? For omitting local therapy in that setting, I think the answer is no. For omitting surgery in that setting, I think the answer is maybe, and I'll go into that as well. And then finally, there's a question of, okay, I understand that the indication that the SNMMI is saying, the indication that the FDA is saying, NCCN is saying, is for, looking at for distant metastatic disease, but can PET PSMA help us localize occult high-grade disease within the prostate? I think the answer to that is maybe. So let's go through that a little bit. First, the question of, should unfavorable intermediate prostate cancer, should that be staged at all with PET PSMA? Are we wasting resources by doing that? And I think it's important to sort of understand that for men with unfavorable intermediate prostate cancer, they often, at diagnosis that you think might be clinically localized, they often do have positive extra prostatic and extra pelvic findings. There's a recent study by Hagens et al. In the Journal of Nuclear Medicine that looked at about 400 men that had otherwise NCCN unfavorable intermediate risk prostate cancer that underwent PET imaging. And they found that about 9% of the cases showed some disease either in a lymph node or metastatic. And actually 43% of them were M1s, they were metastatic. There were some features that could tell you who with unfavorable intermediate risk disease might be more likely to have a positive PET scan for extra prostatic disease. And these were tumor volume as defined by a PIRADS 5 lesion on MRI, that's a bulkier lesion, sometimes with EPE, or high number of core involved, like more than 50% of the cores involved. We looked at this in our Northwestern series. We had 123 men with unfavorable intermediate risk disease that were then staged with the PET PSMA. And we had similar findings. About 10% of them were clinical N1 or M1. That's one of our residents, Eric Lee, with a manuscript in preparation. What predicted guys that would have a positive PET PSMA? So if you're going to withhold it from someone who not to withhold it from, it'd be someone with 2 or more unfavorable intermediate risk factors. They had a 4-fold increase in the chance that they would have extra prostatic disease. So unfavorable intermediate risk prostate cancer should be staged by PET PSMA, in my opinion, before making a decision about what to do next. So what if you do stage them and you find that the PET PSMA only lights up in the prostate and you're planning to do surgery? should you omit a pelvic lymph node dissection? I think here is again important to understand some of the nuances around PET imaging. PET PSMA is more sensitive than conventional imaging, but it can't really detect lesions that are smaller than about 3 millimeters in size. And so, there's a chance that you're going to miss lymph nodes that are small but positive for prostate cancer. And we can see that if we look at some of the studies with things like, DCFPYL, so the Polarify compound, or if we look at things like the Posluma compound, those studies are Osprey and Lighthouse that used a pathological standard of truth. So they were saying, all right, if we had people with negative conventional imaging, you did the PET scan, and then you're going to take them to surgery and look at the lymph nodes, how often are you finding stuff? How often are you missing stuff? And the bar graphs I showed there on the left are looking at the Osprey study, which was looking at DCF-PYL, PET PSMA. And you can see a couple things. You can see, A, that the specificity is very high, positive predictive value is high. So that's shown here in these middle bars. So the specificity is like 98% specific. So if the person has a lymph node that's lit up by the PET PSMA, and I'm thinking about a prostatectomy, I need to counsel that gentleman that it's extremely likely that lymph node is going to be positive, and we're going to have to think about what we want to do for their therapy afterwards, and do we want to change or pivot. The negative predictive value, however, and particularly if you look at the left among all pelvic lymph nodes, is only about 83%. So, in many cases, and this was shown also in the Lighthouse study that used the RH-PSMA, negative predictive value was about 80%. So in many cases, 15 to 20% of the cases, even if the PET saying the lymph nodes are not involved, they're actually involved with smaller, less than 3 millimeter, cancer deposits usually. And so if you're going to do a lymph node dissection, or you think that it's appropriate to radiate the lymph nodes in the primary setting and the PET's negative, don't use that as your way of saying, well, I know the lymph nodes are not involved. What about if the PET's positive? I mentioned, what if it's N1? What if it's M1 by PET scan? Should we omit local therapy? Well, the answer to that is, no. You should be considering local therapy, whether the PET PSMA is positive or not. Why? Well, in Stampede, when they looked at people with conventional imaging who were metastatic, low volume metastatic, and asked, would these people benefit from local therapy? The answer was yes. They benefited in their oncologic outcomes, and even overall survival from radiation to the prostate if they had low burden metastatic disease. Similar results from other studies as well. The SWOG 1802 study is still ongoing. That's a study using surgery or radiation and best practices, best systemic therapy in men with metastatic disease. So we'll see what kind of role surgery plays. But there's a benefit for local therapy to the prostate, to the pelvis, if the person has low volume metastatic disease. And you might say, okay, well, but if the PET's positive, I don't know how to interpret that. All the definitions for high and low volume disease were done using charted criteria, and those are based on conventional imaging. What do I do with the PET scan? How do I define high or low volume disease on PET PSMA? And again, this may be an obvious point, but it's worth saying it's appropriate, not to rigidly adhere to trial definitions. So you kind of know it when you see it. So even if someone was negative by conventional imaging, but has 10, PET PSMA positive lesions, including bone lesions that are within the appendicular and axial skeleton that are not showing up on a conventional bone scan, that person is probably more like a higher volume guy than a low volume guy. Also, if you do have metastatic disease, it's extremely appropriate to perform conventional imaging, in my opinion. You're probably going to use conventional imaging for your serial follow-up, and so that makes a lot of sense. So, okay, the guy has PET PSMA positive disease. We think he's more like a low volume metastatic guy. We're not going to omit local therapy, but should you use surgery still in that situation? I think that you can counsel the patients, carefully. The majority of patients that have surgery will still require radiation and systemic therapy, and the additional oncologic benefit of surgery to that radiation and systemic therapy is really unclear. It's also different if you think about the N1 people versus the M1 people. For the N1 people, I think it's good to note that if we do surgery on those folks, a lot of them will develop a ultra-sensitive undetectable PSA, and some of them will remain there. There's a recent medical student at Northwestern looked at our series of N1 prostate cancers at prostatectomy, and about 12% of those guys with kind of a shorter term follow-up, median of 2 years, showed that they could get to a less than 0.01 PSA and stay there even if their nodes were positive. And then when he looked to see what if they were clinical N1 by like a PET going in, obviously the number of these guys is even smaller, that didn't seem to significantly affect the outcomes. So I think that for N1 disease, if you're strongly motivated for surgery, understand some of the caveats and that they often will need more treatment, it makes sense. For M1 disease, I think that you're even more careful about your decision making in those cases for adding surgery. And then finally, in terms of the PET imaging for initial staging, we were talking about staging for metastatic disease in that setting, and that's where the approvals are. But can we find occult disease in the prostate by using the PET PSMA? Can we expand the indication? There's lots of studies, kind of a meta-analysis shown here, that about 90% of the cases you can see prostate cancer in the prostate. And even sort of in this busy slide, what you see is that the PET PSMA positivity goes up with Gleason grade, and so does PSMA expression. So if you look at like Gleason grade group 1 disease and you compare, PET PSMA accuracy to something like MRI to finding Gleason grade 1 disease, they're about 60% accurate, and adding the PET to the MR to look at local prostate cancer within the prostate doesn't really help much. But for Gleason grade group 2 or 3 disease, you can improve the accuracy of just MRI, which we usually use to best image prostate cancer within the prostate. You can improve that accuracy by almost 10%, mostly by adding in sensitivity for detection of this occult, maybe Gleason grade group 3 disease or 2 disease, doing a PET MRI. And we're looking at that more closely with the folks at Blue Earth. They like I mentioned, they have their rh-PSMA 7.3 compound that's been FDA approved. We're looking at, are there some men with low or intermediate risk prostate cancer and maybe some feature that would make their cancer more aggressive, like a deciphered genomic classifier of the intermediate or high risk, where the PET MR, if done, and then you got a pathological, biopsy or did a prostatectomy, you would find occult higher grade disease. How often does that happen? Can PET MR be used to detect that? Again, for distant staging, doing PET PSMA, for example, on a person who has favorable intermediate risk prostate cancer is not really supported by guidelines. When we look at our series, there were 17 such individuals who got a PET PSMA for looking for distant disease, and none of them had true positives. But this is the question of can it help us with local understanding of, did we undersample the patient even if they previously had an MRI guided biopsy of their prostate? That's what this trial is looking at, and the answer right now is maybe. So finally, how about in the biochemical recurrence setting for PET PSMA, or biochemical persistence setting? There the uptake of PET PSMA was basically instant, at least within our institution. This is the same kind of cohorts looked at by Richie Bennett, showing that uptake, even when PET was first approved with PET PSMA, was about 90% in our cohort, and now it's about 100% of people at biochemical recurrence is getting a PET PSMA. It's nice to look at some of the detection limits and understand those better. If we look at the first compounds that came to market, the gallium PSMA 11 and the F18 DCF PYL, you can see that for low PSAs, where we usually are trying to figure things out for these patients in terms of their next steps in therapy, whether they have gone through surgery and you're thinking about salvage radiation and how to do the treatment planning, or better still, surgery and radiation, and now they have the PSAs rise and you want to see, could they be a candidate for metastasis-directed therapy? The detection rate for PSAs less than 0.5 appears to be around, high 30s, maybe 40% for these compounds. If we look in our Northwestern series, this is by one of our residents, Eric Lee, on the left, you can see that it's again around 37% detection rate on the PET PSMA if the if the PSA is around 0.5 or less. The sorry about that. There's like the new kid on the block, like I mentioned, was the RH PSMA, and interestingly, now there's no head-to-head comparisons, but in their spotlight study where they looked at biochemically recurrent patients, they can see at low PSAs less than 0.5, the detection rates can be, in the mid 60%. And there was a study by Rashner a couple of years ago where they looked at a retrospective series of patients with PSA of 0.2 to 0.5 that were imaged by RH-PSMA, and those showed about a 62% also positivity rate. And so, again, there's no head-to-heads, but RH-PSMA 7.3 is a little bit more hydrophobic, less urinary excretion. Maybe it's better at picking up some of the prostate bed recurrences and local recurrences in that initial biochemical recurrence. But there's no head-to-head comparisons, but I'm excited about this new agent on the market so I can test that out and see how it uses in my practice. In general, what this is telling us also is that even when I used to wait myself until the PSA was about 0.4, 0.5 before I pulled the trigger on imaging, because there is like another inflection point around there. But now with this data, if someone comes to see me and I'm wondering about salvage therapies and their PSA after treatments with surgery or surgery and radiation is in that 0.2 to 0.5 category, I'm getting the PET PSMA. So just a final note on PSMA, as I mentioned earlier, radioligand therapy is also available. This is where you would take something like, say, lutetium-177, you would bind it to your PSMA molecule. That would make it then radioactive. It's going into the prostate cell, kind of homing into that PSMA receptor, gets internalized, deposits its payload, and kills the prostate cancer. And we saw for this lutetium-177 PSMA 617, for example, we had an FDA approval in the people with metastatic castrate-resistant prostate cancer that had been previously treated with docetaxel or taxane, one or two type taxanes, and a novel hormonal therapy like enzalutamide, abiraterone. And those people in the VISION study showed here had a overall survival advantage, a progression-free survival advantage compared to best standard of care. And in this series, in this series that we're doing tonight, there are videos online. Dr. Vanderweel gave a great presentation summarizing some of this, a year back or so. Regardless, what we saw this year was we saw some maturing earlier studies. So at ESMO this year, PSMA-4 was published. This is basically looking at the same compound, this lutetium-177 radioligand therapy, so PSMA-targeted radioligand therapy with lutetium-177. But now instead of like heavily pretreated, metastatic CRPC, they're looking at chemo-naive, CRPC. These people were randomized to either having a change in their androgen receptor pathway inhibitor or to getting the lutetium-177. The primary outcome of the trial was radiographic progression-free survival. And they did that so that they could then allow crossover, and a lot of people did crossover. In fact, the majority of people who progressed on a switch of their AR blocker crossed over to get lutetium-177. But this trial that was discussed at ESMO by Dr. Sartor was positive. So the progression-free survival in these less heavily pretreated metastatic castrate-resistant prostate cancer patients was positive. They had a 6-month median increase in their progression-free survival, as you can see here, which was pretty significant. And the treatment emergent adverse events that were happening, hematologic and otherwise, appeared less in this less pretreated population than they did in the VISION patients that often were further along in their cancer therapies and thus more quote unquote beat up. Kind of, also adding on to this, we saw at least reports of the top top line, findings from Splash. Splash was a very similar trial design to this PSMA-4 trial. It's also metastatic castration-resistant prostate cancer, chemo naive, comparing a lutetium PSMA targeted agent. In this case, it's Lantheus's PNT 2002 agent bound to lutetium-177, but again, PSMA targeted versus an ARPI switch. And they were looking at progression-free survival as their primary endpoint, again, positive with a hazard ratio of about 0.71 in kind of early analysis. And then finally, we saw another trial reported at ESMO by Dr. Emmett and colleagues, the ENZA-P trial, where they were taking metastatic CRPC in the first line, randomizing them to enzalutamide or enzalutamide with lutetium PSMA, and they found that the addition of lutetium PSMA improved PSA progression-free survival. The other outcomes aren't mature, but they're already seeing early signal there. So radioligand therapy, is here already FDA approved for post chemo and novel hormonal therapy, CRPC, but now we're seeing data that's probably going to allow us to move it earlier in space. And indeed, there's trials that are fully accrued, including PSMA addition that we ran here at Northwestern, and multiple other places ran it as well. That now are fully accrued. We're waiting for results that are looking at moving it even earlier in space to hormone-sensitive prostate cancer.
Ashley, it's Ted.
Yeah.
Can I ask a question?
Sure.
So, what is your impression of the outcome in those early radioligand trials? My impression was, sure, they met their endpoint and they had a impact on progression-free or OS. But how big is that impact in your mind, and what's the bang that you get for your buck?
So I think there's two things. I think that my impression is I was actually fairly impressed with the PSMA-4 outcomes. I think that might be, well, I guess a couple things. The Vision trial I thought in itself was still fairly impressive, even though there weren't many options available to those patients. The PSMA-4 trial, which I'll go back to, this one, I also find that this progression-free survival benefit, that 6-month benefit, without having really significant, serious adverse events compared to the AR switch, I also find this to be impressive. Now, the major criticism is that, they were comparing basically what was in most cases an inactive therapy, like you're switching from, abiraterone to enzalutamide versus you're getting this PSMA-based therapy. And that's a criticism. And I think that's one reason that the overall survival outcomes don't look as good. But the overall survival outcomes don't look as good.
Just for clarification, so a better trial would have been like lutetium versus like cabazitaxel or something like that? Would that have been?
Yeah, Vision allowed for best standard of care versus or dealer's choice versus use of the lutetium compound. PSMA-4 was again switch versus this compound. That all said, the switch we often do in our practices, but it's not surprising to me that the overall survival, which isn't fully mature but didn't look that great, because so many people progressed on the control arm and they allowed crossover. I think it was like 80% of the people who progressed and were allowed to did cross over to get the then active, lutetium PSMA therapy. You can also make a comment about, well, for treatment emergent events, how can you think about that and reduce toxicity and get high efficacy? The ENZA-P trial that Emmett did, they basically gave 2 doses and then they re-imaged the patients to see, do they still have avid, PSMA avid lesions? And if they did, then they would continue to give 2 more doses. And I think that's a smarter way of doing it too. So I have not had, I think the patients are were over the moon excited about, radioligand therapy. It sounds great, and the patients were over the moon. I wasn't at that high level of over the moon about this, and then I would say that the modest effects seen on Vision, and these are great effects, but they're still they're good. They didn't, they didn't take the wind out of my sails completely, but I think that what it showed me is this is definitely an active agent. I think everyone on this call, including yourself, believes it's definitely an active agent. The question is, how do we best utilize it, and where's the sweet spot to get its bang for a buck? We're going to talk about PARP inhibitors later. For me, if I was like first line CRPC and I could be offered a PARP inhibitor or a PET PSMA agent, and I was a BRCA2 altered individual, I would choose a first line therapy using the PARP inhibitor as my first thing. But if I was going to think about, well, do I want to take docetaxel versus one of these agents, like a lutetium PSMA agent, then I would say, well, what does my PET scan look like? How high is my uptake, the SUV uptake? Do I have any questionable lesions that are not, uptaking as much of the tracer, uptaking no tracer? We're not quite allowed to do, where we don't get FDG PETs in these settings. But that if I have any FDG avidity, I might stay away from from a lutetium PSMA agent. But if I have a very high SUV, mean SUV, I'm going to lean towards, taking one of these agents if particularly if I'm not, BRCA altered. So I think there is a lot of teeth here, and the excitement is sort of justified. I'm going to be curious to see what happens in PSMA addition, but that's kind of my 2 cents. I don't know if anyone else is we can have a minor conversation around this. If anyone else on the call kind of wants to give their 2 cents, please feel free.
Ash, this is David, and that was sort of the discussion at ESMO, is that this is a tool, and just like every other tool, you think about how best to deploy it. And I guess I think about the same way. How do you prioritize it? And I agree, the biomarker here is the imaging. And I've had a guy with SUV max, a lot of lymph nodes, but one large lymph node sort of conglomeration with the SUV max over 100, and his PSA dropped from 110 to undetectable with 2 or 3 cycles of lutetium, and then we stopped, and we haven't started up again, and that was 6 to 8 months ago. That's my outlier, really positive case, but there are others who have had excellent responses. But I do think the SUV is pretty helpful. And I've been using, in our colleagues in Nuke Med and Radiology have been great about adding on SUV max, SUV mean to try to help us make those decisions. And I've found that really helpful. And you're right, it's not the silver bullet that a lot of patients were thinking and a lot of providers were hoping for, but it is active, especially in some folks.
Yeah, that's excellently put. And sort of transitioning to like sort of the next thing, and as we talk about metastatic prostate cancer, particularly at presentation, and we go into like from something new, the PSMA targeted agents are going to be the be all and end all. All the way back to like a century plus ago, saying like no AR, the prostate cancer is the most it's an AR addicted cancer. What's going on new in 2023 as we go into 2024 or begin 2024 with AR targeted therapies? Well, what we know is, for metastatic disease, all the preferred regimens from the NCCN are using, androgen deprivation therapy and some other androgen signaling blockade, whether it be more of a production blockade with abiraterone, or it's going to be an androgen receptor, pathway or androgen receptor inhibitor like, apalutamide, enzalutamide, darolutamide. All the preferred strategies are building on more, blockade with the androgen signaling. And what we can see is that even though metastatic disease presents in multiple different ways, you can have your on the far left here, you can have your metacratous presentation where you treated the local disease, and then later on the person has metastatic sites. or you can have your synchronous de novo metastatic folks that have low or high volume. And even though those presentations affect how the person's going to do in general and what their trajectories are prognostically, in all those settings, what you find is that adding on a androgen receptor signaling inhibitor, whether it be abiraterone or apalutamide or enzalutamide, in all those settings improves outcomes, even in the synchronous progression to M1 disease. So then the question was, well, what if we try to do this where there is no metastatic disease? The guy has M0 disease and is biochemically recurrent, so non-metastatic castrate-sensitive prostate cancer. If we add on another agent, another androgen receptor pathway inhibitor, in this case enzalutamide, can we make outcomes better? And that was sort of the idea around Embark. This is a large randomized trial looking at, excuse me one second. This is a large randomized trial looking at patients with high-risk biochemical recurrent after treatment with surgery, radiation, or surgery and radiation. And high risk was defined both by the PSA doubling time being a little bit faster, less than 9 months, and also by what the PSA level was. So say like after a surgery-containing regimen, a PSA over 1, after radiation, a PSA over 2 at least. And it looked at like randomizing them to getting androgen deprivation alone, in this case leuprolide, versus strategies that included enzalutamide, either enzalutamide with leuprolide or enzalutamide as a monotherapy. After they gave therapy for about 9 months, they checked to see is the PSA undetectable or with outside of the biochemically recurrent threshold of 0.2. And if it was, they would suspend treatment to see what happens. And if it wasn't, you remain on treatment. The primary endpoint for the trial and the primary comparison was enza plus leuprolide, versus leuprolide alone. And the secondary endpoints looked at the monotherapy arm as well. And they were looking at metastasis-free progression in that. So let's look at what happened. So, here on the left, what you can see is the therapies that are using enzalutamide, either the combination therapy, enzalutamide plus leuprolide, or enzalutamide monotherapy. If you compare those strategies to leuprolide alone, shown in the blue for both of these, you see an improvement in metastasis-free survival. That improvement appears, even though they didn't do a comparison of enza plus lupron to enza alone, that appears to be strongest when you have enzalutamide plus leuprolide. That seems to have the best oncological outcomes, followed by then the enzalutamide monotherapy, and then lupron alone. And that's also recapitulated if you look at these results on the right. It's like the extent of the hazard ratios. Enza plus leuprolide in this high-risk BCR setting appears to be very active. It even had an overall survival benefit, which the study is immature for, but that is left of the line, so it has a significant hazard ratio. So enzalutamide improves oncological outcomes in high-risk biochemical recurrence for sure. What else did we learn from the trial? We learned that in the majority of cases, you can only suspend treatment transiently. So if you look at the combination therapy, enza plus leuprolide, that's on the left here, 90% or so of the patients made it to that PSA less than 0.2 at 9 months, and they could suspend therapy. Enzalutamide monotherapy, about 86% of the patients made it there, about 70% of the leuprolide alone made it there, and they all could suspend therapy. But the average treatment suspension, which was highest for the combination arm again, was about 18 months. And about 90% of the patients would have to go back on therapy during the trial. So what else did we learn? We learned that if you use enzalutamide plus leuprolide or enzalutamide alone or leuprolide, you're getting similar rates of adverse events. All of them have about 30% serious adverse events. And there were no big surprises, but it's worth pointing out that the types of adverse events you're getting for enzalutamide monotherapy compared to regimens involving leuprolide differ. So if you have enza alone, you're going to have 3 times less hot flashes but Enza alone is going to give you 5 times more gynecomastia. And so let's kind of like think about that a little bit more and have some like interpretive takeaways, I call it, from the Embark trial. And the Embark trial was a huge effort, but the first interpretive takeaway is like, how does it affect us in the context of what's going on now? PET PSMA imaging that we spent like a half an hour or so talking about, it wasn't around back at Embark. And if we look at our retrospective evidence from things like Northwestern, there's a resident, Nicole Handa here, who looked at that. We look at retrospectively at the Embark type patients, and we asked, like, well, if we did a PET PSMA, what would we find? 20% of those folks would have no positive PET findings. 20% of the patients would have had disease in the prostate or prostate bed only and been amenable to curative therapies. 20% of them would be N as in Nancy 1, and 40% would have been M as in Mary 1. So we have a lot of patients that we would be handling a little bit differently. Now, Embark definitely supports the use of enzalutamide for patients with high-risk BCR, and they're negative by conventional imaging. So it should follow that Embark supports the use of androgen receptor pathway inhibitors, specifically enzalutamide, in PET-avid conventional imaging negative M1 and N1 disease. So that's like so this is basically should be obvious, but again, I'll just point it out. If you have a patient who has like they're only PET avid for metastatic, their conventional imaging was negative, but they have M1 disease by their PET scan, sometimes, there could have been the argument where you said, well, I don't know if I want to add an androgen receptor pathway inhibitor to their ADT. Maybe I'll just use ADT alone. They're not quite metastatic by conventional imaging. What Embark does for us is it does kind of like, in a little bit of a circuitous way, fill in that blank. Like, no, if it works in high-risk BCR and it improves oncological outcomes there, then certainly your person who on PET PSMA is M1, adding that second androgen receptor pathway inhibitor is going to help. And like this helps me in my practice when I get PET PSMA for staging and I'm trying to think, well, should I define this person as M1? It's the more accurate scan, and I think they should be defined as M1, and I should treat them sort of that way. So certainly, again, in metachronous metastatic disease, those are the patients that are like Embark, but intuitively in synchronous metastatic disease, it's sort of helping us in that setting. So how about something a little bit more nuanced? So Embark also is suggestive that, even intensified androgen axis directed systemic therapy is really just suppressive. So part of me, at least, was thinking like, well, maybe if someone's micrometastatic, a high-risk BCR, maybe if we're really using these strong, inhibition of the androgen axis, like these trimodal androgen receptor blockers like enzalutamide, along with their ADT, maybe we can kill those micrometastatic clones and maybe render them into a very deep remission, And I think the 9-month holiday designed in Embark was a very, good thing to do and try and see, does that work? And like I said, about 90% of the patients have to get back on therapy. It was a little bit less. It was more like 80% of the people who got Enza plus leuprolide. But, the majority of patients have to get back on therapy. And it's telling me at least that the systemic therapy is really much more suppressive than completely able to eradicate things. Now, you can argue maybe they didn't give the therapy long enough, but to me, it really points out the importance of using metastasis-directed, radiation therapy when applicable in some of the oligometastatic states. I mean, I think, I quote this paper a lot. I think about it a lot, but it's a very small series. We have the Oriole trial, by Dr. Tran and others, where they didn't use any ADT at all. And if you had, 3 or less lesions that were amenable to metastasis-directed therapy, and you could get all of those lesions, then what they saw was the progression-free survival, METs-free survival was like, 80% with no ADT. So that's pretty provocative. Now, there's trials like Aristep, which is similar to Embark, but it's using darolutamide as opposed to enzalutamide. It's looking at 2-year duration before holiday as opposed to 9 months, and it's allowing for that METs-directed therapy. That and multiple other studies is going to help show us what the power of that radiotherapy is, but it really brought that more into the forefront for me. Finally, and this is actually extremely important, Embark, at least when it comes to enzalutamide, really expands our options to modulate toxicity in our patients. If you have a patient, like I mentioned, that you're going to give enzalutamide and ADT for high-risk BCR, or even in another setting, like let's say oligometastatic setting, that appears to have the best oncological response, without increased serious adverse events. So my starting point in the Embark type patient, if I was the provider, is probably going to be a combinational therapy. But if they're having a lot of problems, let's say with the hot flashes, you now can feel pretty good about saying, I can drop the ADT. They're going to have a good oncological response, albeit at a potential increased risk of gynecomastia, which there's methods to handle. So that was also an important thing from Embark in my eyes. So finally, I'll just kind of spend the last 10 minutes or so going over like those three important approvals for PARP inhibitors in advanced prostate cancer. And I think, this again should be old hash, but we're going to kind of just drive it home a little bit more. 10% of men with advanced prostate cancer, or I should say up to 10% of men, will have germline mutations in their DNA damage repair machinery. Up to 30% of castrate-resistant prostate cancer can develop germline or somatic alterations in DNA damage repair machinery. PARP inhibitors, as I mentioned earlier, have been FDA approved for selective men with metastatic CRPC. And it may be that androgen receptor blockade or androgen inhibition, signaling inhibition, can augment the response to PARP-based therapies. So just so we can just drive it home one more time, because again, PARP inhibitors are still relatively new to prostate cancer. Dr. Hussein gave a great talk a couple years back at this series on this. I'll tell you to go check it out. But again, just to go over it, what do PARPs do? PARPs are involved in DNA damage repair, particularly base excision repair. In the normal cell, you've got, a break in the DNA, say it's a single strand break, the PARP proteins can come in and fix it. Or if the single strand break comes a double strand break, you have things like BRCA and the homologous repair machinery that can come in and fix that and repair that damage and keep the cell going. Now, cancer cells will often try to get rid of some of their DNA repair machinery, become a little bit more permissive around developing mutations, maybe getting through different cell cycle checkpoints, and that includes loss of things like BRCA that can affect the homologous recombination. That cancer cell can prevent itself from getting into like catastrophic genomic trouble because it still has that PARP around. Now, if you go in and you use a PARP inhibitor, and they have already one leg of that three-legged stool kind of kicked out with the loss of the homologous recombination, loss of BRCA, then you can kick out another leg from that stool and you get catastrophic DNA instability and cell death. And that's the idea of like synthetic lethality with like sort of PARP inhibitors in the setting of a DNA damage repair deficiency. And this was, shown for other cancers, ovarian, breast, etc. And then, we had FDA approvals of olaparib first, and then rucaparib as monotherapies in castrate-resistant prostate cancer that had homologous recombination repair deficiencies. So the PROfound trial, which Dr. Hussein had talked about, said olaparib could be used in metastatic castrate-resistant prostate cancer after you've used another androgen receptor signaling inhibitor. The Triton, 2 and 3 trials led to rucaparib's approval, which the FDA approval is after an androgen receptor signaling inhibitor and docetaxel. There were 3 approvals this year that came from combinational strategies in first-line metastatic CRPC. Those are from the PROPEL trial, which used olaparib and abi, the Magnitude trial that used niraparib and abi, and the TALAPRO-2 trial that used talazoparib and enzalutamide. All 3 of those had FDA approvals this year, and the FDA approved, the PROPEL strategy and the Magnitude strategy, meaning the olaparib and niraparib combinations for BRCA-altered men with metastatic CRPC, and they're a little bit broader indication for talazoparib and enzalutamide, where it included up to 12 types of homologous recombination repair deficiencies. In all of these different studies, however, the biggest effect is in those BRCA-altered men. Here's the progression-free survival of 0.2, which is just phenomenal in BRCA-altered men from PROPEL, 0.5 from Magnitude, and 0.45 from TALAPRO-2. So what are we taking home from this as we wrap up? And for these studies, what we're taking home is that, look, for PARP inhibitors in prostate cancer, we know that they're most effective in BRCA altered patients. They're also approved in other homologous recombination repair altered patients in some settings. What we have to do, particularly my colleagues who are urologists, we have to be very proactive about either getting patients involved in genetic testing, or at least planting the seeds in their mind that these are good options for them. All men with metastatic disease should have germline testing to look to see, are they going to be candidates for these drugs? How does that affect their families? How does it affect other malignancies they may develop? You can make some arguments that maybe we should do somatic testing there as well. All men with metastatic castration-resistant prostate cancer should have at least somatic next-gen sequencing, and if they had not had germline sequencing, germline as well. So one feature of the PARP inhibitors are they're going to work the best in BRCA altered patients in particular. You're never going to know it unless you can test. We looked at our series, 3 years ago here, and the testing rates were lower than what we want. We want like 100% testing in these populations. Also shared among the PARP inhibitors are some of their toxicities. These are oral, targeted therapies, but they have hematological toxicities, particularly anemia, sometimes thrombocytopenia. Very, very rarely, MDS is reported. They have gastrointestinal side effects as well. So, as we get towards the end of the hour, and I know it's a little bit of a whirlwind, but a lot's going on, what are our take-home points? We can have a couple minutes for discussion. One, PET PSMA, really should be the preferred method of initial staging for newly diagnosed risk-appropriate prostate cancer and biochemical recurrence. Should also be used to identify patients that might benefit from radioligand therapy, and we, that's true for heavily pretreated metastatic castration-resistant prostate cancer. We're seeing that can move earlier in space. We also have seen this year that enzalutamide improves oncological outcomes for patients with high-risk biochemical recurrence, and its use as a monotherapy can now be considered, and that can help us kind of tailor our therapy to toxicities. And finally, PARP inhibition improves oncological outcomes in men with metastatic castration-resistant prostate cancer and DNA damage repair alterations, particularly BRCA. So testing them, testing men for this is critical. Those therapies are very active, particularly in the BRCA altered men. So I'll stop there. A little bit of a whirlwind, a great earlier discussion, and we have about 4 minutes to take more questions, and we're going to save 1 minute at the end to talk about the timing of this talk, and not what I just gave, but the timing of this lecture series and whether we want to change it. But before we get into that, any other questions or thoughts?
So is there a difference in the false negative rate in PET imaging for unfavorable intermediate versus high risk patients?
No. Well, we have not seen that. Well, I should say this in a different way. True false negatives, yes, there's more false negatives in unfavorable intermediate risk disease than in high risk disease, and that was shown in like the particularly when they did Lighthouse, which was the Spotlight, Lighthouse, where they did the RH PSMA 7.3 in initial staging. What they saw was there were more false negatives in unfavorable intermediate risk disease than there was in high risk disease, and the reason for that was the lymph nodes that were positive. That was a pathologic standard of truth. The lymph nodes that are positive in unfavorable intermediate risk disease when you do prostatectomy versus high risk disease tend to be smaller. So they tend to be like like I had a guy last week who had a 0.1 millimeter deposit in one lymph node, and his PET PSMA pre-op was negative, but obviously they're never going to detect that 0.1 millimeter. So, with that caveat, absolutely the answer is yes.
So should you do a more extensive lymph node dissection for people with favorable and unfavorable intermediate risk prostate cancer than the high risk guys?
That's also an interesting question. I think that there's two parts to it. I actually have taken my lead from you. So I would say, favorable intermediate risk, what we've seen in our series is even if you're favorable intermediate risk and you have a high genomic score, like even a high genomic, high decipher, favorable intermediate risk disease, and you're worried that guy's going to have maybe they're going to have a lymph node, they're going to get upstaged. About 40% of our guys get upstaged to or upgraded to 4 + 3 = 7. Some of them have T3B. None of the people at our Northwestern series with those parameters, they were favorable intermediate risk and even a high risk decipher. None of them had node positive disease. We're looking back at that series to make sure, but none of them that we've seen. So, I think that they haven't quite crossed that line. We're looking at that more closely in our investigator initiated study, but I would say you do not have to go, really extensive and maybe, risk causing a complication for the person for a guy with favorable intermediate risk disease. Now, for unfavorable intermediate risk disease, you're looking for those small deposits. And, I don't know if that's going to be a stalled tumor or not, but like I mentioned, I was actually delighted and surprised to see that about 10% of our patients at Northwestern, where they get those lymph node dissections, have an ultra sensitive undetectable PSA basically forever, right? If we go back in time like 15, 20 years, the Messing trial would tell us to put those guys on ADT for life, but they're actually fine for life. And that's prompted me to kind of go by what you taught me, which is like the least dangerous place to develop a bad complication, meaning like lymphedema if we had to salvage that guy with radiation, and a primary landing zone for a lot of these lymph nodes is in that hypogastric and deep pelvis. So if I have a guy who is unfavorable intermediate risk or high risk, and I want to make sure I clear that out to prevent them from needing more therapy, I do go for it more aggressively there, versus someone where they're high risk, and I know that my lymph node dissection is not going to be necessarily curative. I may be a little bit altered. In the cases that I really go for it for the high risk or very high risk guy is if there is PET avidity and we decide to have surgery, or if there is a bulky lymph node that I think that like it's going to be hard to downsize that and get it fully eradicated with radiation, I'll go for those bulky lymph nodes. Again, this is based on very loose evidence, but I think that paradigm of like is kind of has helped me well. I very, very, very rarely, I don't think anyone at Northwestern does this anymore, go kind of like do the cystectomy type lymph node dissection where I go above and lateral to the artery. I was doing that for a little while. That's the external iliac artery. And then when those guys got salvaged radiation, they were getting, I had 2 cases of lymphedema, and that's a very difficult problem to have. Thanks for everyone's time.